Hi, I'm HD Chambers, and you're listening to ImpactED. I want to thank all of those of you who are either listening or watching this episode. As always, myself, our school board, our district is appreciative of those of you who have interest in our school district and have interest in things related to public education. And if you've listened to us at all, you know that we talk about all kinds of topics that are either specifically about public ed or in some degree impact education of our kids. So today we're talking with a gentleman that I've gotten to know over the last, 9 or 10 months, I guess, through the COVID experience, Dr. Eric Boerwinkle. And I'm going to let him introduce himself and tell a little bit about himself in 1 second. And why I believe, I know that this conversation is going to be of critical importance to staff members and to adults across the community and to our listening audience as it relates to the vaccines that are currently being distributed and the vaccines that are currently getting close to being distributed. And so today's conversation is with Dr. Boerwinkle, and we're going to talk about a lot of things COVID related, but we want to spend some time maybe answering some questions you may have in your mind about the vaccine or the vaccines and the a little bit of history behind that, because there's a lot of questions that have come up. So hopefully this will be beneficial and helpful to everyone. So Eric, thank you again for joining us. And if you don't mind, maybe just talk a little bit about yourself and kind of the relevance that your role that you've been playing professionally and how it's become at the forefront right now, to be honest with you. Yeah.
Well, thank you, HD, and thank all the listeners to ImpactED. It's a real pleasure to be here. Like a lot of us, the road between a small town sort of farm boy to being a dean is a long and twisted road. I am a product of public education, and I'm also a product of state university systems, which I'm very proud of both of those things. So I was born in Ohio and went to the University of Cincinnati. And, I went to Cincinnati because it was relatively small and I wasn't really used to big cities, and I didn't want to go to, Ohio State or whatever. Then from there, I went to the other side over at Ann Arbor at the University of Michigan. And from there, I moved directly to Texas. And I've never looked back. So I've been at the University of Texas Health Science Center in Houston really for 33 years now, which is really hard to believe. It's gone extremely fast.
And you're the dean. You're the dean of health sciences.
I am, and so I've I rose through the ranks from somebody who was 26 years old at the time. I was the youngest professor in all of the UT system, or youngest faculty member in the UT system. And I rose all the way through to being a professor and didn't duck at the right moment. And therefore, I'm now the dean. I'm the proud and humble, I'm humbled to be the dean of the University of Texas Health Science Center, or now called UTHealth, School of Public Health. And the schools is very different than many schools or universities that you think about, that we're sitting in Houston, Texas right now, and there's multiple medical schools. But across the state, in UT, there's only one school of public health. And I've got campuses here in Houston, up in Dallas, and San Antonio, Austin, Brownsville, and El Paso. And, Texas is a big state. And, you drive from here to El Paso, you're halfway to Los Angeles. But it gives us I'd say a unique perspective really of health, the health of Texas, the health of Texans, which has been very important as we now turn in the discussion and sort of my journey and how in the heck did I get involved in COVID. Let me first say to your listeners that I'm not a traditional infectious disease epidemiologist. It turned out I was trained in statistics. I'm quite good in mathematics when I was younger. And so I understand numbers. I understand numbers and the dynamics of numbers. But the most important thing is I really value working with people and interdisciplinary teams, and how you bring together statisticians, epidemiologists, physicians, computer scientists, and make sure every one of them is valued and understands the mission, really. And so, when COVID came on the scene, I very quickly realized that there was enormous need, first in terms of modeling. And we did a lot of modeling and prediction, even in the very earliest days when, your listeners probably can remember when COVID was something that was in Seattle, and very tragic experience in a nursing home in the Seattle area, and also in New York. But it was inevitable it would be in Texas. In fact, it would be wherever your listeners are, which I understand are really all over the world. There isn't a place where COVID is missed. And so really it was quite an experience really then to go from, first modeling and then analyzing the trends in our populations, the local health departments, including our state health departments, and frankly, across the state. They tend to be under budgeted and understaffed. Before the pandemic, they did a lot of work, for example, in restaurant, health, the public health is just extremely diverse. But they didn't have really the expertise for a lot of analytics. And so we basically offered that. And now more recently, it's been kind of interesting that I skipped this important chapter. My training was primarily in genetics, which is a strange story in and of itself. I actually thought I would probably go into agricultural genetics and grow or breed the next strain of corn, but became very interested in human genetics and how we can understand variation in humans and how that contributes to variation in disease susceptibility. Now we think about COVID and how we think about a person is infected with a virus and how they respond to that virus. And so we're interested then in really the sequence of the virus. And that's, I hope we can talk a little bit about these new variants that might be arising. And then also the final kind of comment, as I just touch on a number of subjects, is really the technology to these vaccines that we're now seeing. I think it's important for all of us, include, myself included, to remind ourselves that it typically takes about 10 years, between the onset of an epidemic to the time you might think of having a vaccine. And we've compressed that 10 years in the case of COVID down to 10 months, which is really a scientific miracle. And I think all of us should pause for a minute and think about just the amazing advances that are around us in science that have allowed this to happen. So that is my sort of, kind of a strange journey,
right?
To come to this point, and it's a lot of work, but it is also a lot of fun.
Well, this is, I mean, COVID has thrust a lot of people in the healthcare profession into the public's eye, just because of everybody wants to know. And you talking about your background in genetics and mathematics. I'll just tell those that are listening or watching this that being a part of these conversations every week with you and Dr. Callender and others from the Texas Medical Center, because I always wondered where did the data come from? Where did the numbers come from? Where did literally down to zip code about the transmission rates and all that. And I don't want to get into that because it, first of all, give me a headache trying to think about all of it. But I guess the data that you guys use and your staff uses to project and to predict and to try to give physicians who are working on this a fighting chance to maybe head it off at the pass. I've always Wayne Gretzky was always asked, what made you such a great hockey player? And he always talked about how he played the game with where the puck was going to be versus where it was.
That's right.
Do you see yourself in that kind of regard where you're trying to tell us where we're going so we can prepare for it as opposed to where we've been? Or
That's absolutely right. And I use that Gretzky quote.
yeah, I've heard you.
Yeah.
I've heard you. I wanted to see if you recognize that.
We use that Gretzky quote. And I'll just give our listeners just one example of, now that we're rolling out vaccine, and we're, it's now February the 26th, I guess it is, right? And, we're at an important point here because we've been in a situation, and my guess is all of your listeners are in this situation, where we just frankly have a shortage of vaccine. But now we see the amount of vaccine ramping up, and it's ramping up really, for two very important reasons. Number one is those that are approved. As we talk today, that means the Pfizer vaccine and the Moderna vaccine. Those two companies, in partnership with others, are ramping up production. And the other is we're bringing on, hopefully, knock on wood, two new vaccines, the Johnson & Johnson vaccine and also, one from AstraZeneca. So we'll see an uptick in the availability of vaccine. And why I'm going through this is really these analyses then are helping both healthcare and public health, local public health departments, to understand where are the geographic regions that have been most impacted. Because you want to get the vaccine to those people who need it most. Those people are at very high risk of disease. So right now, I'd say most of the analyses we're doing are really predicting when we make this transition of having more available vaccine, of how to get it to those people who are most high risk and most in need. And that's just one example.
So let's talk about that, because the vaccines themselves, because you made a comment earlier about how we took typically a 10-year process and made it, turned it into something less than a year. I'm just curious, what is the process for vaccines? I mean, you take a pandemic. I don't know how to say an average pandemic. Take a pandemic, and in the past, one, what took so long, and then two, why in this case was it able to be done so quickly? Yeah,
and it's a great question. First let's step back and ask how it's quote unquote usually done. Although it's it's a strange word. Often what happens is scientists either have a way of killing the foreign substance. Let's say, it's a virus, they debilitate it so it can't replicate, or they isolate a particular protein. Thinking about this, the SARS-CoV-2 virus, that's the virus that causes COVID. I mean, everybody's seen cartoons. In fact, I saw recently a cupcake at a bakery shop that was that was decorated to look like the SARS-CoV-2 virus.
Yeah, we've celebrated now. It's a celebrity.
That's right. And so it has these spike proteins. So, for example, so typically what happens is the scientists who are working, they isolate the protein or they kill the virus. They inject that into an individual. Let's say we'll go all the way to the vaccine then. And then your body recognizes that as a foreign substance. And your body, your body has amazing abilities to recognize foreign substances and has ways of combating those infections. They're either by production of antibodies or the sort of initiation and revving up of they're called T cells, and those cells can help combat the infection. And so that's really the way a traditional vaccine works. It's the word is attenuated. It really means the virus is basically killed, so it can't replicate. And and for example, a very famous example is remember the stories about the smallpox vaccine and people using cowpox. So they basically used a relative that came from a cow, and didn't really inject it and had to scrape and put it in the person through some sort of a scrape, and that had an immune response that helped protect them later from smallpox. So that's sort of the traditional route. But in this particular case, what was happening is people were trying to figure out, isolating a protein or killing a virus is just figuring out how to do it is a lot of work. It's a huge amount of work. But you think about the DNA sequence itself, and it goes back to, again, being trained in geneticists. The genetic code is, on the one hand, one of the most amazing things in nature. But on the other hand, it's the simplest and most boring book you could ever read. It goes A, T, G, C, A, T, G, C. There's only 4 letters. And it turns out in 2020 or 21, we have the technology to produce a lot of DNA. We can synthesize it. So now what was done and what the actual vaccine from Pfizer and Moderna is, if you remember high school biology, DNA makes RNA, then makes protein. So instead of injecting the protein, they just inject some of this RNA. They inject the RNA into your arm, and your own body then takes the RNA and synthesizes the spike protein. And so now you've actually have this foreign substance produced by your own body, by the way, in your arm. And it turned out that many companies, including Pfizer, for example, were experimenting with this. And so when the opportunity came to put that new technology into production, they were ready.
So they were already experimenting with the idea prior to COVID.
That's right, prior to COVID. And so when the virus was very quickly isolated and sequenced in China originally, before it even entered the U.S., we had the sequence. They quickly could identify the spike protein as sticking on the outside. They could very quickly synthesize that RNA and then very quickly start to experiment with the safety of getting into your arm. And then again, trying to ramp up production. And we should probably come back to that for a minute, but I want to take a little bit of a sidebar. There's a lot of interest in these new variants, whether it's the UK variant or whether it's South African or New York, California, and it's going to continue, by the way.
This is what viruses do.
That's what viruses do. They're going to mutate to try to continuously propagate themselves and escape your immunity. That's their life,
Right.
But the neat thing is now that we have a safe vaccine, because it's this RNA base that's injected into your arm. I don't want to say it's easy, but it's as close to easy as you can get. All they have to do is tweak the sequence of that vaccine to update it for the new variants. So many of your listeners, HD, have already heard that we may be seeing next year a booster, or even in the fall a booster, or the formulation for the vaccine may be changing over time. And that's natural. So what the companies are doing is tweaking the sequence of that RNA to make sure that the antibodies that are produced will recognize these new variants as they pop up. And the list, we should all, and the listener should remind ourselves, that's really not that different than what happened in the flu vaccine.
Right.
You always hear every year that there are scientists, a lot of them at the CDC, they're analyzing what flus are out there, and they're going to formulate the vaccine for this coming year. And that's really what's happening here. Is we're looking what are the sequences and of the coronavirus that are out there, and how do we best formulate the sequence of the RNA that's going to go into people's arms. So I'm actually quite optimistic about the role of the vaccines. I do want to talk a little bit about, because in the first few weeks in particular, it almost became a spectator sport to criticize the rollout of the vaccine. But I think we all have to just remind ourselves that this occurred so fast And the trials, by the way, did not go fast. Those trials were done very carefully to show that this vaccine is safe and effective. So don't think just because I use the word fast that it was done either in a sloppy way.
Well, I think a lot of people were worried about that
that's right.
Because something must have been skipped, or some process must have been skipped. Therefore, I'm going to be afraid to take it until a bunch of people take it and prove that they're not going to get sick.
Yeah. Yep.
Were the trials any different? I mean, was the timing of trials any different for COVID than they would have been for something else? Or can you even answer that? They may all be different, I guess.
They're all different, but these trials were different. They were different for two reasons. One is, it won't surprise any of us that there was a strong feeling of urgency.
Yeah.
COVID is killing a lot of people. I would guess that almost all of your listeners know someone, or I'm sorry to say, have a loved one who has died of COVID. And so there was a sense of urgency. The other reason it was different is this RNA has to be kept extremely cold, minus 80 degrees centigrade. That's really, really cold. And so, the logistics of moving this vaccine around,
Yeah, to put it in perspective, it's colder than last week, right?
It was a lot colder than last week, even though, for those listeners who are not, we're not used to cold weather here in South Texas or the Houston area. So it crippled us.
Right. Well, I know that we're well into the distribution of the vaccines. I mean, we're into it in terms of time. Obviously, not nearly the percentage of our population has gotten their shot yet that you would like, but the process and the role that the people like yourself and others that are who studied this. I'm thank you for the clarification, because there's my own self. I was wondering. I said, my goodness, was it the sense of urgency, or was it countries working together? I've talked to some doctors that have said, for the first time in a long time, countries actually work together, probably more so than they've ever done before. At least scientists. Is that true? Or
the scientists actually in the trenches do a great job working together. Yeah. Government sharing data, often less so. So, having the trials and having data that was shared internationally is something new. And again, it was a sense of urgency that we needed to cooperate.
Well, go back to the rollout. You were getting ready to talk about the massive. I mean, I've said this. I thought the expectations that were built up were almost going to be impossible to be met. In other words, there was over expectation and under delivery, which is cardinal sin for sales. But would you agree with that?
I don't know where it came from. It may have come from each one of our hopes that it was going to ramp up quickly. Yeah. But again, because of how quick the discovery process, the trials, frankly, to produce and distribute tens of millions of vials of this vaccine, there was enormous production, not difficulties, but logistics, of all the logistics that had to occur, and they all had to occur at the right time, the right place. And it had to be done in a sterile way. I mean, even those little tiny glass vials that the vaccine is put into and then shipped in, frankly, what looks like a pizza box. If you haven't seen one yet, it really does look like a pizza box. And they come to us, and we put them in these minus 80 freezers. This all had to work so well, and it just took time. For those of you who follow the news, that Europe, for example, is behind, and a lot of that is because the plant that is producing the Pfizer vaccine is in Belgium, and that had to just be totally retooled to do this. So there was production difficulties, and again, it's just a whole lot of logistics that have to work.
I wonder, are there enough freezers to get that type of freezer to hold that many vaccines? I mean, do we have enough of those?
We do, in I can tell you in Houston, we're in good shape because of the Texas Medical Center. I mean, I have about 120 of those freezers because of my own work that are typically, we sample individuals from literally all over the world to isolate their DNA, to sequence their DNA, to look at risk of disease. And so we have blood and plasma and DNA. And so what we did is very quickly reorganize things and freed up 5 or 6 freezers that could be used by the Texas medical institutions and our local public health departments. And you may have heard that one of the local health departments had a bit of a problem with the freezer and had to scramble both to very quickly get arms to get the vaccine that was already prepared and then find a new freezer. So it's the logistics of this are difficult in a city that has, for the listeners, that Houston is the home of the Texas Medical Center, which is one of the largest medical centers in the world and one of the best. And so there's an enormous clinical enterprise here, but there's also an enormous research enterprise.
Yeah.
So we're well prepared for this. I think where it's going to get difficult is making sure rural America is served, and that's why the Johnson & Johnson vaccine and the AstraZeneca vaccine couldn't be coming out at a better time. Those 2 vaccines only need to be refrigerated, and so because again, having an ultra cold, what we call an ultra cold freezer, it's a heavy lift.
I mean, in layman's terms, what's the difference between a vaccine that only requires one shot versus those that require 2 shots? Can you explain what's happening there?
Sure. So what you want from any vaccine is you want what's called an immune response. You're actually taking a needle and injecting a foreign substance into your body. Your body recognizes it as foreign and it begins to produce antibodies. And those antibodies then, we hope, stay around for, let's say, approximately a year. That's why you have to get a flu vaccine, for example, every year, because of the age of those, how long does one's immune response last? And so you need to have the substance that you're injecting basically induce enough of a response that it protects you, number one, and it protects you for approximately a year, number 2. And then for reasons that are not always well understood, and even when they're understood, they're very complicated. Some of those, vaccines or these foreign substances, they don't elicit an immune response that's high enough and long enough lasting. And so it takes 2 shots, that initial shot and what some people then call a booster, to get enough of an immune response and get a long enough immune response. Both of those are important. The Johnson & Johnson vaccine, because of, peculiarities of what's being injected, again, the spike protein, the tests, the clinical trials show that it has a high enough response and lasts long enough that you only need a single shot. So that's another valuable advance in terms of making sure we get literally tens and hundreds of millions of people vaccinated. I do want to make a clear statement, and I'll probably repeat this. All of these vaccines, when you think about protecting ourselves from serious disease and serious consequences of COVID, all of these vaccines work extremely well. And in fact, to my surprise, they all work much, much better than a typical flu vaccine, and so they all work. And so my strong advice to the listeners is, when you're offered a chance for the vaccine, take it. Simple, very simple. When you're offered a chance to receive the COVID vaccine, take it. It is shown to protect from serious disease. It is shown to protect your own life. So take it. And don't kind of don't overthink or try to game the system that I'm going to take vaccine, 1 versus 2 versus 3 versus 4. They all work.
Yeah.
They all work.
Yeah. I think, just anecdotal that people that want the vaccine, obviously right now it's quantity. So it's just a matter of getting enough of them and getting to a point where you do have herd immunity, which will take a while. So you're saying that potentially this becomes something of an annual thing that we're gonna have to look at, because there's I heard Dr. Fauci or someone used the term zero COVID. There is no such thing as, not anymore, right? There's no such thing as zero COVID, just like there's no such thing as zero influenza.
Right. I don't think we should be thinking about a zero COVID. It's truly a pandemic.
Yeah.
And we've shown that it can be controlled. I think that's an important point too to make, that don't think that we're going to beat COVID by vaccines alone. We're in a period where the vaccine certainly helping us. I'm extremely enthusiastic about the vaccine, but we're still going to need to be wearing masks through the summer. We're still going to need to limit social distancing and avoiding large crowds. If you've been exposed and your public health department calls you to participate in contact tracing, please participate. It's important, particularly as these new variants are popping up and you may have been exposed to one. It's important that we try to wall that off and nip it in the bud as fast as possible. Don't tell your local public health department that your name is Donald Duck or George Washington or whatever. It's just they're collecting the information for the good of your health and the health of others. And as somebody who works very closely with these data, it's not being collected for nefarious purposes.
Yeah.
And so it's important that we all participate. Really is.
Yeah, there's always a lack or a distrust at certain levels of government and bureaucracy, and we all have to deal with that. I've heard people say, well, as soon as we get rid of COVID, as soon as the vaccine is out there and COVID is going away, there's no such thing as COVID going away, and so I hope everyone understands at some point, whenever society gets back to to some sense of comfort. I'm not going to use the term normal, but when we get back to a sense of comfort where large groups can gather without having masks on and large groups can gather without having socially distanced, at whatever point that is.
Yeah.
I think we need to keep repeating to people that there's still going to be cases of COVID. It just won't be like it is right now, obviously,
That's right.
So
that's right. And and again, I'm an optimistic, I think, by character, but I'm also optimistic, thinking about the science of this, that we will get to a point that, I'm frustrated. I get frustrated. I want to go visit my kids. We'll get to a point where we can, and we can with relative safety. And it'll be a combination of things they're going to get us to that point, including vaccines and periodic boosters, etc. But we can handle that.
It's a math problem, right? I mean,
it is.
At some point. I mean, I don't mean to be insensitive about the science. I mean, the health and what's occurred to over 500,000 Americans, but it does become a math problem. Yeah. Yeah.
And it's interesting. You use this word herd immunity. It's important, to kind of think about that a little bit. It's going to herd immunity. Well, first of all, what is it? Particularly for Texans, I think we understand herd immunity. For those of you who vaccinate cattle, if you miss a few, you're okay.
Right.
Because, basically whatever bug you're trying to save the herd from, if it can't be transmitted from animal to animal to animal, you'll basically knock it down. That those few unvaccinated animals in the herd, typically are saved, and humans are really no different. And so if we can, out in the population, if you think about wherever your listener is, think about your community. If you can get 75 or 80% of the people that have antibodies, then, you'll start to enjoy a certain amount of protection. And so there's a couple of important points in that sentence. Number one is herd immunity. It's not like you cross a line, let's say 80%, and you didn't have it, and over the line you have it. It's a quantitative thing. And we're not seeing it yet, but we're going to start to see it here in, I would say, the next month. You're going to start to see the impact of having larger and larger numbers of people vaccinated. The other point is we're not starting from zero.
Right, right.
We're not starting from zero. That, we are carrying out the nation's largest, what's called seroprevalence. We're looking at who has antibodies to the naturally occurring infection. And in Texas, I can tell you the average across the state is about 22% of us. So let's
22%
have the antibodies.
Have the antibodies as a result of having COVID?
They have had COVID, whether they know it or not. Most of them don't know it, by the way.
Yeah. Yeah.
Most of them answer the question, because we ask them, have you had COVID? We also ask them about symptoms. And most of them, they say they've never had COVID, et cetera, and they have antibodies. And so we're not starting from zero. And again, let's come back to the importance of topic of children. The frequency in children is even higher. The frequency of children in Texas with antibodies is about 30%. So it's not quite a third. And that's just because, kids, fortunately for all of us, they obviously do get the virus, but most of them are asymptomatic.
Yeah.
And what we have to worry about with kids is them taking it home to grandma and giving the virus to grandma. She gets very seriously ill. But the kids, it's about 30%. And so, when we think about herd immunity, we're really thinking about what I call the naturally occurring antibody, because I can't think of a better word.
Yeah.
Plus the antibodies from the vaccine. So we're going to get there. Good.
Well, for those that are listening, I've been, Dr. Boerwinkle has been one of the more optimistic people as we've gone through these conversations. But I say that not jokingly, because you do deal with the data, the numbers, and while there's some emotion that gets involved in that, the numbers are what the numbers are. And all of the information that the county puts out in the city of Houston, and all the transmission rate and the positivity rates and all those things kind of come from your shop. They come from you accumulating this information to the best of your ability and trying to replicate that. Is that fair in terms of what your responsibilities have been in that regard?
That's what we do. Yeah. And, I'm fortunate, like I said, that we analyze these data and try to make a picture of the data that our healthcare, our workers, our elected officials, school leaders like yourself, HD, so you can make better decisions. I'm very careful myself, and I talk to my team a lot about we don't make policy. We try to take data, turn that data into information, and then present that information in an unbiased way so other people can pull the levers of government, or pull the levers of a business or of a school system to respond to the best information that we can provide. That's what I see as our goal in this. And what we do is not perfect. I can tell you the data is not always perfect. And if you want to talk about how to make mistakes, I think I wrote the book at it. But we do the best we can to provide accurate and timely information so other people can make the decisions they need to make. And I think the other important point is this pandemic it surprises all of us almost. It used to be weekly, probably now it's monthly. It changes. we're here in February. That peak we saw in January was different than the peak we saw in summer,
Right.
and it was different than the peak we saw in March. And so you have to first remain humble. Don't think you know it all.
Yeah.
And we remain humble and keep analyzing, keep learning. So hopefully we can stay ahead of this.
And we're concerned about spring break coming up. I mean, the surge in January in large part was a result of Christmas and New Year's and family gatherings, and where you're more susceptible to not wearing a mask and not socially distancing. So, we want to continue talking about the safety and security of people because of spring break coming up. And
right, absolutely right. That we can't, particularly now. There's been a lot of analogies. I tend not to like sort of the military analogies, but I think right now we're in a race. We're in a race with the virus, and we have the tools now to win this race. And the best tools we have are the vaccine and the public health measures that we can win this. So please, everyone, including myself and you, HD, is please now, as we see light at the end of the tunnel, let's not let our guard down, and let's keep the numbers down. We're on this downward slope that we saw. For this region, we entered it around January the 10th. Here we are in sort of late February. Let's keep driving the numbers down, because as the numbers get lower and lower, there's a couple things that are going to happen. Number one is contact tracing is going to work.
Mm-hmm. Mm-hmm.
It's actually going to work. When you have small numbers or relatively small numbers, you can actually do a lot of good contact tracing and walk the virus off. That's been a problem. That's been a big problem in schools. Yeah, is you just got teachers and kids all over the place, and it's hard to successfully and accurately contact trace. No question. Right. And the other is there's a strange phenomenon as we drive the frequency, the infection down. I'll say this slowly because you got to kind of wrap your head around this. The actual numbers of viruses that are out there are smaller. And when the numbers of viruses are smaller, there's less of a chance to accumulate new mutations. And so we got to get ahead of these new mutations. And so if we can basically keep these numbers low, treat the people treat the infections we have, wall off the new ones, we can get ahead of these new variants and get ahead of this virus. That's going to be the key. And before, I think we were a little bit of hamsters on the wheel. There was just so much infection out there. And HD, every once in a while you'd see these maps. What can you do in the whole? We talk about
everything's red.
Yeah,
everything's red.
We talk about hot spots. The entire region's red. What are you going to do? I know. I'm sorry for laughing, but it's just it's crazy. You get yourself wrapped up in it. But that's not the case now.
Right.
We are driving the numbers down. The whole area is not red. So let's double down and make an effort. Yeah.
What you mentioned in a meeting this morning, in a previous meeting you and I were in, you made a comment about one of the things that we've learned is that human beings do have control over this. Yeah. To a certain extent, or to a large extent. I mean, our behaviors and our decision making and all that. Before we wrap up, talk a little bit about what have we learned from this? I mean, not only the scientific field, but what you just said, human behavior, the way in which humans, which there is no genetic code that can control that, it seems.
Yeah. So, let's just step back for a minute and talk about in the Houston area. We saw a big peak in the summer. They came down, and then we saw one and after Christmas that went up, and now we're coming down. And these peaks came down before the vaccine. And so the important part is the vaccine didn't bring them down. We brought them down by our behavior. And so I don't whether it's fear, which I actually think is, fear is a powerful motivator. Mm. And so I believe, fear was a factor. We, fear for ourselves and our loved ones, fear for our neighbors. we see the numbers go high. We hear about it on the news. So we all behave ourselves. We all wear masks. We avoid restaurants or larger gatherings, whatever. And then we see the numbers come down, and then we let our guard down. We think it's okay to have the neighbors over or whatever. And then they go right back up. It's like a roller coaster. So human behavior has been extremely, a powerful driver in all of this. But I also think we have to be careful. I started, maybe it's good to loop back towards the end, is, I'm very fortunate. I'm very lucky. If I think that I have COVID, I can go get tested. I may be positive and I can stay home for 10 days and I can work on my computer at home. We forget, I'm very, very lucky. There's a lot of people in our community, they can't do that. They can't do that. And so we need to keep that in mind. We need to develop a system that protects all of us. And so we just, we all do what we can do to fight this virus, and we just need to remember that.
So, Eric, you mentioned when you introduced yourself, you were a product of public schools or a public education, and
yes,
and I would venture to say that 80-90% of the men and women who were responsible for such a miraculous creation of this vaccine in such a short amount of time are probably products of public education. And I'm not bashing private, or I'm not. What I'm saying is that the criticalness of the public education system to the success and to fighting off something like this, like the COVID virus. Would you spend just a second, because you and I have talked about this before, just a second about the opportunities for students in the health science field, and maybe people don't realize what you do, and they may not even realize what genetics is, or the interest in that, because they don't even realize that. But talk just a second, so kids that are listening to this may benefit from, I may want to look into that.
Yeah, well, first, thanks for asking, because I remain passionate about education. I am a dean of a school.
Yeah.
And I think it's interesting if you just, in your mind, play back the last 30 minutes of all the things we've talked about. There's science, there's traditional science and biology. There's healthcare, the traditional business of healthcare, of physicians and nurses. There's analyzing the data. There's the communications. How do you communicate behaviors? There's engineering. How, if you try to, play a YouTube video of a production facility for one of these vaccines, and, don't think about the biology of the vaccine. Just think about that little bottle moving down through there and all the little parts. There's just enormous opportunity for people, all people, in health and in science and in engineering. And I think too often, as I go and visit schools, for example, when people think about healthcare, all they think about is a doctor. I want to be a doctor, and I have many friends that are doctors, and I love the physicians that I work with. But it's important to think about the extremely broad availability of sort of opportunity. I think that's the right word, just the broad availability of opportunities in healthcare and science for all of the young listeners out there. And I just want to give you a reassuring message that those opportunities are available to you, to each and every one of you. You don't have to basically, unless you want to, spend, like I did, spend a quarter of my life in school. Yeah. You don't have to do that. There's just a lot of opportunity, because it literally takes a team. If you recall, when I introduced myself, as I think my strongest asset, I'm not that smart. Come on. My strongest asset is really the ability to talk to people, to rally the troops along a common vision, get people to see the vision, and get everybody involved in that vision. All the way from, the people in sort of the circle that advises me, the people analyzing the data, to the people that actually make it happen. And so to the students that may be listening this, I don't care if you're in elementary school or in college, really think about the science and healthcare and engineering as open to you. I think too many times people think the reach is too high. Either I'm not smart enough, or I don't have the money for it, or the time for it. I can assure you that you are smart enough to do this, that there are opportunities out there for scholarships. There's community colleges. There's now training opportunity, vocational training opportunities in these areas. So I would encourage you, if you're interested in these kinds of things, including genetics, by the way.
Yeah.
It's, I'm fascinated. When I was a student in genetics, you typically either went into agriculture or you were interested in very serious diseases, and there are very few opportunities. But now, because of the biotech industry, has just exploded. Mm-hmm. And those biotech companies are hiring. They're hiring at all levels. They're hiring in for many different components. It's not just biology or medicine. It's like I said, you've got to move this vaccine from discovery into a person's arm. The number of steps is just mind-boggling, and the number of variable steps are mind-boggling. And each and every one of the kids that are listening, there's a role there for you. I assure you of that.
Great. Well, thank you for that, Eric. I appreciate that. And I know that wasn't our topic today, but I have spent 2 years of doing ImpactED episodes, and probably the most common topic I talk to people about is opportunities for young men and young women, particularly from our district, and particularly from low income areas and areas that have large populations of non-English speaking kiddos. And I'm hoping, I'm not going to call it a silver lining, but I'm hoping that a lesson that some people learn out of this experience is that some of our younger people could look at roles and responsibilities like yours and say, you know what, that interests me. I didn't even know that existed. So that's an ongoing challenge we have with students today, is trying to find them something they could actually be excited about. Mm-hmm. So, yeah. Well, thank you, sir.
I'm lucky. I'll be clear. I love my work. I love my work.
Me too. I'm the same way. I'm extremely blessed in that regard. So, Eric, thank you very much. I really do, and I just want everyone to know, Eric and his colleagues in the medical center have been just outstanding resources for us. And I know that he mentioned earlier he was doing everything he could do to help us make decisions and do our jobs, and he has. And I know he's got a team underneath him that works. But anyway, thank you for coming on and sharing your insight. It is appreciated.
Thank you, HD, and thank you to all the listeners of ImpactED. Appreciate the opportunity.
Absolutely. So this has been ImpactED. I'm HD Chambers with Alief ISD. Thank you, guys. Have a great day, and we'll talk to you soon.
This has been an AMP production.